Good evening, everyone, and welcome to yet another class on AOC and Fundamental Lecture Series for Pediatricians. And today is a very interesting topic by a very interesting speaker, Dr. Lakshmi, and he's going to take us through the journey of epilepsy. When you get a child with epilepsy, how to approach the child, how to do a basic stepwise approach. And that's very, very important to know because it's one of the commonest disorder in our OPDs, in pediatric OPD as well as neurology OPD. So to moderate this session, we have Dr. Vaikunta Raju. He's a pediatric neurologist in Bengaluru. And can you project the slides, Sneha? Yeah, he has done his DM pediatric neurology from AIMS, and I'll say that he is one of the most hardworking, silently working, and a workaholic pediatric neurologist I've ever met. And he's now professor of pediatric neurology at Indira Gandhi Institute of Child Health, Bangalore. And he's more than 125 publications, and he's the author of a textbook, which again he wrote very silently. And I'll welcome him, and I'll hand over the stage to him to introduce the speaker. And okay, to you.
Thanks, Gurupreet. So today will be talk on approach to epilepsy by Dr. Lakshmi Narayan. So he's a consultant epileptologist and pediatric neurologist at Advanced Center for Epilepsy, Glen Global Health City in Chennai. He has done DM pediatrics and DM pediatric neurology at AIMS New Delhi. Afterwards, he has done fellowship in epilepsy and EEG for 2 years at Royal Children's Hospital in Australia. And he is also faculty at Asian Epilepsy Academy EEG course for neurologists in South India. And he is a member of highly pediatric epilepsy surgery task force. And he is a convener of Young Epilepsy section in Indian Epilepsy Society. And he is executive member of AOC and he has career interest in drug-resistant epilepsy and epilepsy surgery. He has many publications. So to Dr. Lakshmi Narayan.
Very good evening, everyone. First of all, I would like to thank Dr. Raju sir for the kind words, and I would also like to express my gratitude to the office bearers of Association of Child Neurology and the Education Committee, including Dr. Gurpreet Kochar and Dr. Naveen Sankyan, for this invitation to be talking amongst you. Quickly share the slide. So today we will be going through the stepwise approach to a seizure or epilepsy in children. So the presentation we will take it through: is it a seizure? Is it epilepsy? What tests are to be carried out and how to treat? So coming to the clinical diagnosis, one of the most common scenario in the pediatric OPD is a typically developing child brought with history of abnormal face jerking movements along with the excess of drooling of saliva that lasted for 2 to 3 minutes that occurred the previous night out of sleep. So when you examine this child, you will invariably find that the child is completely normal neurologically as well as general examination wise. So normal intellectual child with the first episode of nocturnal seizure and normal examination. So the most common questions that both the attending doctor and the parents would ask at this point is, what was it? Was it an epileptic seizure or was it a seizure mimic? Was it provoked seizure or unprovoked seizure? What was the cause? And what tests need to be done to prove the cause? Will it recur again? That is one of the single most important questions that any parent would ask you. And some parents would ask you, when will it recur? So what are the treatments to be done and for how long? That's the most important question. Nowadays, parents are not very keen to continue medication beyond few months. When we say these medication to be given for at least 3 years, the first reaction is a shock. So the question to answer whether is it a seizure or not, I wish there is a confirmatory test that will tell you that is it a seizure or not. Unfortunately, there is no such a test available to make a diagnosis of seizure or epilepsy, because seizure and epilepsy are clinical diagnoses. So the paroxysmal movements in children are very, very, very common. Distinguishing between seizures and seizure mimics and other paroxysmal episodes are purely clinical. And this is the first critical step in the diagnostic pathway. The moment you go wrong in this first step, all the subsequent steps will be wrong. That is why you have to be really, really be accurate at this step. And that's why we spend a lot of time on the diagnosis. So how do we make the clinical diagnosis of seizure and epilepsy? So this is by a time-tested method of a careful, in-depth, detailed history, usually by the first-hand eyewitness. What are the things that we deal with in the detailed history? The context in which the episode occurred, whether the child was sleeping, whether the child was playing, whether the child was crying, whether the child got upset, whether the child was running during the episode, and how did the episode start? What was the earliest symptom? What was the first symptom? What was the first change noticed in the child? And how did the clinical signs progressed during the episode? And how did it end? And what were the phenomena that occurred just after the end of the episode, that is post-ictal phase? So all these piece of information are important. This is like a big jigsaw puzzle. If you miss one piece of the puzzle also, then you won't have a complete picture. Single most important thing, especially if the child is old enough, you need to talk to the child, because the aura, the subjective sensation at the start of the seizure or a prodromal symptom in case of syncope can only be described by the child, because that is subjective. You won't get this information otherwise. And get the eyewitness to act out the episode. That is very, very important. What was the episode look like? What was the episode looking like? But many times this acting out could be very inaccurate. So that caveat is always there. So we don't go by 100% whether it is how it is acted out. Many times the first episode or the recent episode might have occurred at school. So the parents may be completely unaware of what was the semiology, what was the phenomenology during the episode. So we might have to talk to the teacher or the classmates or the friends who witnessed the episode over phone, or if they are available along with the patient. Review of the home video, that's a single most important step, because many a times the home video, the episode that are captured on the video can be the one that clinches the diagnosis. The single most important pointer here is the situation, the context in which the episode occurred. I'll give you an example. There is a 7-month-old infant who gets upset, crying vigorously, and then suddenly stops crying, holds breath, goes limp, and completely cyanosed, unresponsive for next 1 minute, then recovers. We all have had this patient, and this is breath holding spell. This is not epileptic seizure. So the context was most important, because the child got upset. The child wanted a toy and that was refused. So the child got upset, cried, hyperventilated, went into this episode. On the other hand, another 7-month-old infant, which had the same events of going limp, unresponsive, cyanosed, but the context was the child was happily playing, there was no upset, there was no hyperventilating, vigorous cry before the episode. That means that is not breath-holding spell, that could be a focal seizure. Focal seizure again can have exactly all the sequence of the events that I described, including cyanosis, going limp, unresponsive, uprolled eyes, everything. So the context was most important to decide whether it was a breath holding spell or a focal seizure. So it's not the individual event that is more important. Overall constellation of symptoms, the overall flavor of the episode, that need to be taken in the holistic approach to decide whether it's a seizure or a non-epileptic event. Because this is a single most important step, and there is no single investigation that this can be outsourced to. So we need to encourage home videos. So coming to the first step, deciding whether this is a seizure or seizure mimic, the differential diagnosis can be quite exhaustive and depends on the age, because we as pediatricians deal with a newborn baby to a 100 kilo weighing over obese adolescent or young adult. So depending on the age, in infancy, the most common seizure mimic that we would come across is a breath-holding spell and shuddering attack, apart from benign neonatal sleep myoclonus. And stereotypy and daydreaming can be there in toddlers. Tics and parasomnia is the most common phenomena that we would come across in the middle childhood. Older children, syncope and psychogenic non-epileptic attacks. These are the two most important differential diagnoses that we should not miss anytime, because these are the common ones that are misclassified as epilepsy. So not to forget the psychogenic non-epileptic attacks. That's much more common, much more underdiagnosed. Many patients who are treated with 4 or 5 anti-epileptic medications as drug-resistant epilepsy can be having only psychogenic non-epileptic attacks rather than epilepsy. So this is very, very, very important differential diagnosis. Many patients with epilepsy can have psychogenic non-epileptic attacks in addition to their true seizures also. That is a bit tricky to differentiate. Which one is a true seizure? Which one is a psychogenic attack? Sometimes it need to be clarified on video EEG. There usually is a psychological basis, there usually is acute stressor, but again, an individual child, it may be very difficult to elicit. But if you are not going to elicit and address the underlying psychological factor, this will not remit completely. So the early identification and definite treatment of psychogenic attacks result in excellent prognosis and they go into long-term remission. But if you allow this to go on without appropriate intervention, then the chronic cases can be difficult to treat. So in epilepsy diagnosis, there are 3 axes. The first is the seizure type. So till now we discussed whether it's a seizure or seizure mimic. Then once you are sure that this is a seizure, you need to look at whether it's a provoked seizure or unprovoked seizure. As pediatricians, we are very aware of febrile seizure being one of the most common provoked seizure. Some kids will have seizures during upper respiratory infection or acute gastroenteritis and diarrhea without fever also, but that also has the same implication, same connotation as febrile seizure. So these are the provoked seizures. Another common group of provoked seizures being acute symptomatic seizures with hypoglycemia, hyponatremia, hypocalcemia, one of the most common causes, vitamin D deficiency and hypocalcemia, and neuroinfection, common scenario in India being viral encephalitis and acute bacterial meningitis. These are causes of acute symptomatic seizures. So these are provoked seizures. In epilepsy, what we are dealing with are unprovoked seizures without any of these provocative factors. So once we know that this is an unprovoked seizure, then we need to go into the details of whether it's a focal seizure or generalized seizure. So the most recent ILAE classification 2017 that gives you the different types of focal onset seizures, in which you can have awareness that is retained as well as awareness that are impaired. In generalized onset seizures, you can have generalized onset motor seizure, non-motor seizure, typical non-motor seizure being absent seizure. Sometimes even after all the detailed history, at this point, only historical clinical OPD based diagnosis of focal onset or generalized onset seizure, sometimes this can be unknown onset also. So this is a seizure type. Once we know that the seizure is a focal onset seizure or generalized onset seizure, that is purely based on history, then we go on to classify the epilepsy type. That is again a focal epilepsy or generalized epilepsy or combined focal and generalized epilepsy. Sometimes even after detailed evaluation, it can be unknown type of epilepsy also. So for this, we take the initial clinical diagnosis of the seizure type as well as the EEG finding. So at this point, this is electroclinical, EEG plus clinical. So epilepsy type is classified mainly based on EEG finding. In addition, neuroimaging, CT, MRI findings also will be considered at this point to classify this as focal versus generalized epilepsy. Once we have done that, the third axis is epilepsy syndromes. That I will come to it in a second. The fourth one being epilepsy etiology, underlying etiology. At every step, we need to look at what is the etiology, broadly classified as genetic, structural, metabolic, immune, autoimmune, infectious, and unknown etiology. And not to forget the comorbidities. Many children with epilepsy can have intellectual disability, developmental delay, speech delay, autism, hyperactivity, attention deficit disorder. All these are common comorbidities. So we need to have a holistic diagnosis to have a holistic management plan. So coming to the concept of epilepsy syndrome, the epilepsy syndrome are usually the diagnosis based on clinical as well as EEG finding. So it's an electroclinical diagnosis. Usually the epilepsy syndromes will have a typical age at onset, typical age at remission, manifest usually at certain age. So this is basically age dependent phenomena. Usually characteristic seizure types, say for example, if it is a West syndrome, we all know the infantile spasm is a characteristic seizure type. And if it is a Ohtahara syndrome, then tonic spasm is a seizure type. If it is a childhood absence epilepsy, typical absence seizure is a characteristic seizure type of that epilepsy syndrome. Then the typical EEG findings, interictal as well as ictal findings can be very characteristic for a given electroclinical syndrome, and the clinical course and the prognosis and the treatment implications are all very unique to each syndrome. So the epilepsy syndromes are the constellation of many clinical electrographic findings in addition to the etiology as well. Say for example, Dravet syndrome, we all know it's genetic. So the etiology also is part of this epilepsy clinical syndrome diagnosis. But having said that, some of the epilepsy syndromes are etiology specific. Most of the epilepsy syndromes are etiology non-specific. Say for example, West syndrome can be caused by 400 different etiological factors. So it is etiology non-specific. On the other hand, there is a CDKL5 related developmental encephalopathy that is very specific single gene disorder. So the epilepsy syndrome can be etiology specific, etiology non-specific. So for this electroclinical diagnosis, we need to have a very good quality awake and sleep EEG that are done very detailed, and correct recognition of these syndromes are very, very, very important. Why? Because this will avoid confusion about the diagnosis. This will avoid unnecessary expensive investigations. Say for example, you are diagnosing a child. The first case scenario I told you, a typical developing 5-year-old child with the first nocturnal seizure with unilateral facial clonic jerking and profuse salivation. We all know that is a nocturnal seizure of benign Rolandic epilepsy. Once you know that syndrome, you are not going to order MRI for that patient. You are not going to order genetic testing for the patient. You are not going to order um, uh, all different panels of metabolic testing, all that. So all those can be unnecessary in that scenario and can be cost effective if these are avoided. And appropriate treatment can be chosen. Say for example, if you are correctly recognizing West syndrome, you will start the patient correctly on hormonal treatment with ACTH injection or oral prednisolone rather than going through phenobarbital or phenytoin or valproate that are usually given in infantile epilepsy. Right. So appropriate medication is chosen based on the epilepsy syndrome. And the standard treatment protocols can be used. Again, the best example is West syndrome, where we use a very standardized protocol for oral prednisolone or injection ACTH. Some of the common epilepsy syndromes that we come across in infancy and childhood are enumerated here. In this, we'll briefly talk about West syndrome, benign Rolandic epilepsy, and childhood absence epilepsy in this talk. So epilepsy, so basically different syndromes can be presenting at different age group. When you come across epileptic spasm, one of the most important factors here is many a times the epileptic spasm or infantile spasm and myoclonic jerk or myoclonic seizure are misclassified and interchangeably used. Even now, we come across many PGs, pediatric postgraduates, and beginners, and many times experienced pediatricians are also calling epileptic spasms as myoclonic seizures. That's a bit of confusion, because if you are calling it a myoclonic seizure, then you're not going to attach that much importance to that, because myoclonic seizures happen all the time in many different syndromes, many different etiologies, many different scenarios. So the infantile spasm and West syndrome that need to be given emergency importance for the evaluation as well as treatment, that will get diluted if we call these seizures as myoclonus. So that is one of the most important factor that we need to remember. Another important factor is, many a times, even after the parents show you the video of epileptic spasms or infantile spasms, many a times that can be easily misdiagnosed as a colic or other pain syndromes, or can be misdiagnosed as just a benign phenomena or shuddering attack. So all these misclassification are very common, so that results in later recognition, later treatment. We all know, if the West syndrome is recognized and treated early, you can have a better neurodevelopmental outcome in the long term. So recognizing epileptic spasm is a medical emergency, and EEG typically shows hypsarrhythmia, which is a characteristic finding. MRI should always be ordered. Many times we come across patients with infantile spasms having gone through only one CT scan that is reported as normal. Many years later, we do MRI and we find there is a focal cortical dysplasia sitting in the temporal lobe. That is the cause of this epilepsy, and that could have been easily cured in the infancy itself rather than many years down the line. Treatment protocol is different for epileptic spasms compared to any other epilepsy. So ACTH and prednisolone is the first drug of choice, rather than wasting time on anti-epileptic medications such as valproate or phenobarbital or any other medications. So the triad, we all know: infantile spasms, hypsarrhythmia, and developmental regression or arrest. And these are some of the videos I would like to highlight. So this first baby with black t-shirt, you can see there, you can recognize that the baby has Down syndrome. The face is very typical, and this is a child with Down syndrome and infantile spasms. You can see that one. So that is a subtle bilateral arm abduction, rather adduction here, of epileptic spasms. So other children, the child, this one is a newborn baby. You can see within the first week having these tonic spasms. Though this is not Best syndrome, but this is a tonic spasms of Otahara syndrome. So for the similarity, I've shown here. The third child has a asymmetric epileptic spasm. You can have first jerk on the right arm, then face, then followed by the left arm goes. So this is a asymmetric epileptic spasm. So the importance of recognizing asymmetric epileptic spasms are mostly they are structural. Mostly these are surgically amenable cases of epileptic spasms. And these are other videos of, again, epileptic spasm. So these can be very subtle. If you see, the middle video and the first video are of the same child, and the middle video is the very subtle one. 2 weeks later, the child started having more forceful ones. So if you are not recognizing these subtle ones, then over time they can have more forceful ones. The third one, this baby again has a very subtle infantile spasms. Yeah, only that much. Very subtle. So these videos are very characteristic. You need to spend a lot of time. You need to spend time with the mother of the history of clusters of these phenomena occurring on waking from sleep most of the times. So the clusters and waking from sleep, these are the two most important clues to diagnose epileptic spasms. Usually myoclonic jerks occur randomly and they are not in clusters, and usually they don't have any relation to waking up from sleep. So this is a classical hypsarrhythmia with chaotic background and very high amplitude multifocal spikes predominantly over the posterior head regions, and this is the ictal correlate of epileptic spasm that occurred 3 times in this particular epoch, and this is after arousal from sleep. So this is another child. This child was referred to me as epileptic spasms, but you can see how the child is very attentive, smiling, developmentally normal infant, and having these kind of jerks. So these are basically shuddering attack. So this can be sometimes confused for infantile spasm and vice versa. So coming to drop attacks, that is another peculiar type of seizure that young children have. So most of the times, so phenomena-wise, drop attacks, basically the child suddenly drops, either falling forward or falling backwards. Most of the times these are falling forwards. And there are different seizure types that can present as drop attacks. Epileptic spasms, the most common type that presents with a drop attack. That's why it is called a salam spell. When the child falls forward, it is as though when you fall forward during salam. And aesthetic seizures are another type. So myoclonic aesthetic seizure, the most common epilepsy syndrome that you will have is Deuce syndrome. Again, there will be myoclonic jerk followed by sudden atonic falling forward of the patient. Generalized tonic seizure can have cause falling attack, drop attack, with a slow falling down rather than rapid falling down that you will have in aesthetic seizures. So the prototype of generalized tonic seizure being Lennox-Gastaut syndrome. Negative myoclonic seizures can cause falling attack. Usually they fall slightly backwards, and that can be very prototypically seen in SSPE. Atypical absence seizure, as in atypical benign neurogenic epilepsy, that will cause slow slumping forward falling with gradual falling down attack. And reflex seizures, especially patient with a large porencephalic cyst, you can have a drop attack with sudden noise induced or tactile induced startle seizures. So these are reflex seizures. All these can cause drop attacks. So I'll show you some examples. This child have been having these episodes since I think 8 months of age, but by the time it was recognized and diagnosed and that came to our attention, this was 20 months. So nearly there was a 1 year delay of diagnosis of this patient. You can see the child is neurologically abnormal and squint. So this is a child sitting and having a forward salam, typical salam attack of epileptic spasm with bilateral arm abduction and forward flexion of the neck and trunk. And this again occurs in a cluster. So these are infantile spasm or epileptic spasms causing drop attack. So this is another child. So you can see nicely the child is sitting up and suddenly falling down. So this is atonic seizure, and for next 20-30 seconds the child does not recover, then sits up on his own. There's another patient, exactly similar scenario. So these are basically the child sitting in a nicely padded bed in the video EEG room and having these falls. You can imagine how these falls will be if they are walking around or sitting on a hard surface. So these are very injurious falling attacks. I have come across many kids that have got chronic hematoma of the scalp due to repeated falling attacks. So these are atonic seizures. And this is another child. So you can see the child is walking around with a helmet, and in a second you will realize why that helmet is there. So he was trying to open the door and had a rapid falling forward, and the helmet hit the ground. So that's why he was walking around with a helmet, because he was having multiple daily dropping down attacks with these sudden atonic seizures and causing injurious falls. The same child, now in the frontal view. So now the mother was holding the child, and you can see there's a arm abduction of the right arm, and he is holding with the left arm. So this is a atonic seizure. Actually, this child underwent corpus callosotomy. This was immediate post-op period. You can see the bandage on the head. So after a few months, he completely had remission of these. Now, nearly 2.5 years post-operatively, completely remitted this drop attacks. He is no more walking around with a helmet. So this is another child who had multiple nocturnal seizures. Yeah. So these are very gradual, slow falling down. You can have this contrast. This is a very slow, gradual falling down, falling forward, and partial falling down compared to the previous rapidly falling down. So this is a atypical absence seizure. This child had atypical benign Rolandic epilepsy and having these falling attacks. So we have seen the seizure types, the focal seizure and generalized seizure, and we have discussed about the focal epilepsy and generalized epilepsy, and we have seen examples of few common epilepsy syndromes. So the etiology of the epilepsy is very, very important. At every point of the investigation, every point of the contact, you always have to look at the etiology, because the etiology is the single most important determinant of long-term prognosis, not only of epilepsy remission, but also of long-term neurodevelopmental outcome. So we have to think about etiology at all the steps, and we should not forget something simple like hypocalcemia causing recurrent seizures that does not respond to anti-epileptic medications in infancy, and vitamin D deficiency is very, very common in our part of the world. And think about treatable causes, including vitamin D deficiency, hypocalcemia, and other treatable vitamin responsive epilepsies also, like a pyridoxine deficiency, nicotinic acid responsive seizures, biotinidase deficiency, all that. So coming to what are the common investigations that we do for case of epilepsy. First case scenario, you diagnose a patient with epilepsy clinically, and you order EEG. EEG comes back normal. So what does it mean? So does it rule out epilepsy? So the common myth is a normal EEG rules out epilepsy, but the fact is normal EEG does not rule out epilepsy. There are many different reasons why that is. So for the lack of time, I'm not going to go into that today. The next common myth that people have is the EEG is a confirmatory test, and EEG differentiates between a seizure and seizure mimic. A patient has an episode, you don't know whether it's a seizure or seizure mimic, you can get a EEG and this can be clarified. That is a very common myth among the clinicians, and the fact of this is the seizure and epilepsy or clinical diagnosis, whether it's a seizure or seizure mimic, can be clarified only on the clinical basis. EEG does not have any role to play to differentiate between a seizure or seizure mimic. So this is one of the common indication why EEG is ordered by non-experts. So what do we expect from EEG? So there is a paroxysmal episode and we do EEG. If it comes back abnormal, it is epilepsy. If it comes back normal, it is not epilepsy. So this is what we expect from the EEG. But where do we get this analogy? This is a ECG analogy. So you go to emergency with an acute chest pain. ECG is done. ECG is abnormal. 99.99% it is cardiac origin chest pain. And normal ECG again does not completely rule out cardiac event, but it's a very, very rare to have a normal ECG in an acute coronary event. So we tend to apply the same ECG analogy to the EEG. That is not true. So we learned today normal EEG does not rule out epilepsy. Abnormal EEG per se is not diagnostic of epilepsy. So we always should treat the patient and not the EEG report. So then what is the role of EEG? That means you don't have to do EEG at all. No, there are certain very well defined role for EEG apart from what our myths already I spoke about. So the supporting role is there. EEG is not a confirmatory test, but EEG supports the clinical diagnosis of epilepsy. Say for example, in the first case scenario, typically developing 5-year-old boy with the first nocturnal episode of seizure, you suspected nocturnal seizure of benign neurologic epilepsy. You order EEG in that patient and it comes back as yes, it shows centrotemporal spikes and it confirms your benign neurologic epilepsy. So the role of the EEG is supportive. You clinically know that this is a benign neurologic epilepsy. The EEG only supported that clinical diagnosis. So EEG is not a confirmatory test. The single most important role of EEG is the classification of epilepsy into focal and generalized epilepsy. We talked about first we decide the focal onset or generalized onset seizure, the seizure type. Then we take the help of EEG to classify the seizure type into focal and generalized epilepsy type. So that is the single most important role that EEG plays in the diagnosis of epilepsy, to classify the epilepsy type into focal or generalized. So diagnosis of specific electroclinical epilepsy syndrome, again EEG has a very important role. We already discussed in detail that it is an electroclinical diagnosis. Prognostication, especially the recurrence risk, remission rate, all these can be deducted from the EEG findings. Ascertaining recurrence risk before VAED withdrawal. Say for example, a child with childhood absence epilepsy comes to you and you have given the medication for 1 year and you want to see whether EEG is completely remitted before you want to take the patient off anti-epileptic medication. So if the EEG is completely normal, well recorded, long EEG completely normal, the risk of recurrence in that child is very, very low. On the other hand, there is a child with juvenile myoclonic epilepsy or juvenile absence epilepsy that you get a EEG after 3 or 4 or 5 years of treatment. The EEG is abnormal. That means that child has more than 80% recurrence risk of having seizures if you withdraw the medication. So this is very black and white. It can be in some of the patients. So EEG can ascertain the risk of recurrence post AED withdrawal. Evaluation of first afebrile seizure, EEG has a very important role to play. Exclusion of non-convulsive status, this is very, very important indication. Investigation of acute febrile encephalopathy and unexplained encephalopathy, unexplained global developmental delay, language regression, all these are very important investigations. EEG being a very important investigation in all these scenarios. Coming to another myth, very commonly people think if a EEG comes back abnormal, this confirms epilepsy. Commonly, we come across many infants and pediatrician has correctly diagnosed the episodes as breath holding spell. Even then, they ordered EEG. The EEG comes back as abnormal. Then the clinical diagnosis is breath holding spell. EEG comes back as abnormal, and the patient ends up getting diazepam or clobazam or levetiracetam or sodium valproate just because the EEG is abnormal. So the doctor tends to give more weightage to the EEG abnormality, EEG report, rather than the clinical diagnosis that he correctly did of breath holding spell. So this is a very, very common scenario. So we should not, for this reason, many times we recommend if you are diagnosing a patient with syncope, diagnosing a patient with breath holding spell or shuddering attack clinically, because these are all clinical diagnoses. These are all not investigative diagnosis. So clinically, if you are diagnosing syncope or breath holding spell or shuddering attack, better not to do EEG, because many times EEGs are erroneously reported as abnormal by mistake, but by many times due to many technical reasons. So EEG is a very subjective test. EEG is not like your CT scan or MRI, because what is there on the CT scan and MRI, it is all can easily interpret similarly. But EEG is a very subjective test, so it can be easily misinterpreted. So coming to when not to do EEG. Till now we have seen so many indications for EEG. There are things that you should not order EEG for. So febrile seizure, one of the most common provoked seizure that we come across in pediatric age group, both typical, atypical or complex or prolonged febrile status epilepticus, there are no need for EEG. This is a very well proven evidence wise, because whether if there are transient EEG abnormalities are very common in atypical febrile seizure, whether you are going to treat with daily anti-epileptic medication or not is not the prognostic indicator or determinant of long-term future epilepsy risk. So most of the times, even if there are transient abnormalities in the EEG following febrile status epilepticus or atypical febrile seizures, we are not going to treat these patients with daily anti-epileptic medication prophylaxis. So better not to do EEG in these scenarios. Autism patients, not all of them need EEG, only if they have seizures that are clinically recognized, then we have to do EEG. Why? Because many autism patients can have subclinical EEG abnormalities without having ever had seizures. So these subclinical abnormalities, treating them are not going to alter the prognosis. To differentiate seizure and non-epileptic event, again, EEG is not indicated. Syncope, breath holding spell, shuddering attack, headache, giddiness, all these non-epileptic phenomena, EEG are not to be ordered. In a case of established epilepsy, there is no role for periodic EEG monitoring. We come across many patients with every visit, every 6 months, every 1 year, they get the EEG done. So a patient with epilepsy for 3 or 4 years, they'll have some 7, 8 EEGs with them. That there is no role for such periodic monitoring of the treatment. EEG is basically for diagnosis. So the myth is follow-up EEGs are useful to monitor treatment. The fact is EEG is useful only in the diagnosis in most cases. Very rarely the follow-up EEGs are to be done. There are some exceptions to the rule. We do follow-up EEGs for West syndrome, for epileptic encephalopathies, for CSWS syndrome or any other epileptic encephalopathy, for childhood absence epilepsy, to see whether the EEG is completely cleared. So there are exceptions, but in a focal epilepsy, in a most common types of epilepsies like benign neuronic epilepsy, this is very common. In benign neuronic epilepsy or benign occipital epilepsy, even after clinical remission, they tend to have abnormal EEGs till the time they complete puberty. So for the abnormal EEG, for benign neuronic epilepsy, they are on long-term anti-epileptic medication that are not warranted. So another myth is what we see EEG spikes, the abnormality, the most common abnormality as spikes. Some clinicians, pediatricians think that these spikes per se are the seizures. So the parents are so much worked up, so much anxious about every day my child is having multiple seizures because half an hour EEG showed multiple spikes. So this is another common myth. So the fact is the spikes are interictal finding. They are just a marker of epilepsy. They are not seizures per se. And these spikes are not injurious to the brain. They do not cause any brain damage. Coming to the role of neuroimaging. So basically the MRI is indicated to establish the etiology. If there is a focal lesion, if there is a what kind of focal lesion, what different treatment need to be done. So etiology many times is based on the imaging also. So determine the prognosis. Again, if it is, if the brain imaging shows lissencephaly, if the brain imaging shows bilateral complex cortical malformation, then you know the long-term prognosis for the seizure remission, epilepsy remission, as well as for the neurodevelopmental outcome may not be that great. On the other hand, if the MRI is completely normal and there is no bad genetic epilepsy, then you know that long-term prognosis may be good. In some of the patients, it can identify the different line of treatment. Say, for example, you are treating the patient with only medication. If there is a very localized focal cortical dysplasia, focal cortical malformation is seen, then that child will be benefit from epilepsy surgery. You can remove that malformation and the child can be completely seizure free. So in new onset focal seizure, you can have only 2 or 4% of patients that will have a potential benefit by altering immediate medical or surgical treatment from MRI findings. Most of the times MRI will show some incidental non-specific findings that doesn't have much implication for the treatment. So MRI is the modality of choice. CT scans are not to be done. So MRI should be done. Whenever possible, MRI should be done in a high quality, optimized imaging protocol, not just like that 0.3 or 0.5 Tesla MRI, because there is a clear distinction in the quality of yield of MRI abnormality that we will get. So neuroimaging in epilepsy is not an emergency. Better to wait if you cannot get a good quality optimized MRI rather than rushing and getting a poor quality MRI. So all the MRIs are not the same. and there is a difference between 0.5, 1.5 and 3 Tesla MRI. And in any patient with epilepsy, better to get a good optimized high quality MRI once for all, because this is just for diagnosis. You don't have to repeat these all the time. So role of metabolic and genetic testing is a very important aspect. So not indicated routinely in any patient with epilepsy. Usually the overall clinical phenotype and the MRI usually will have a clue for the underlying metabolic disorder. In most of the neurometabolic disorder, MRI will show some specific finding, MRI will show some abnormality. If a child has epilepsy, developmentally normal, MRI normal, that means it is not metabolic. Most of the times we come across patients with exhaustive metabolic workup done that itself costed around 60-70,000. Then you finally suggest them, this is not metabolic, this is genetic. You have to undergo now genetic testing. They don't have money, so they can miss the specific diagnosis of genetic. So MRI is normal, developmentally normal child, so metabolic testing not indicated. And better to consult pediatric neurologists before ordering clinical whole exome sequencing, because the genetic testing is not as straightforward as we would like, and there is a multiple layers of complexities involved. So many times patients will come back to you with some variant of unknown significance or uncertain significance, VUS, and you don't know, and the geneticists don't know what the implications for these VUS. So it ends up being unpleasant for the whole situation. So better to have a deep clinical phenotyping, that is the most detailed evaluation before you end up doing whole exome sequencing, because it all depends on what is the kind of input you give, what is the kind of clinical details you give. You can't just blame the geneticist for not getting the yield of the genetic testing. So coming to the treatment, we know that we need to treat the patient with no or minimum side effects, and one size fits all does not work in epilepsy. So the epilepsy treatment should be tailor-made. For this, we need to have a precise diagnosis. That's why we spend so much time on diagnosis till now. So principles, we always start the patient on a single dose of medication, small dose, and gradually titrate upwards as the clinical remission happens. The dictum is you should use only as much as needed for the clinical remission of the seizure, but at the same time, you should use only as little as possible. This is though self-evident by literally, but often forgotten in the clinical practice. So how to choose many different anti-epileptic medication? There are so many of them. So how to choose different anti-epileptic medication? We choose based on many variables. Some of the variables are based on the medication. Some of the variables are disease specific. Some of the variables are patient specific. What's an appropriate AED? That depends on the underlying epilepsy syndrome. So infantile spasms we detailedly discussed. Steroids or vigabatrin will be the drug of choice. If it is a generalized epilepsy, usually valproate is the drug of choice. If it is a focal epilepsy, carbamazepine or oxcarbazepine, phenytoin or levetiracetam can be chosen. So many times focal epilepsy patients are on valproate. It's not an ideal situation, because valproate has its own problems, and valproate is not the best medication that you can have for focal epilepsy. So this is just a list of medications for different epilepsy syndromes. So I'll give you one case example again. You can take that first case example I gave you. So basically a patient presents with nocturnal episodes of benign Rolandic epilepsy, and you do the EEG and it shows very typical finding of centrotemporal spikes, and this confirms the diagnosis. So based on this, it's a focal seizure, it's a focal epilepsy, and it's a benign Rolandic epilepsy. Usually there are no associated etiological factors in this case. So MRI is usually not done in any patient with benign Rolandic epilepsy. You don't have to go through general anesthesia and MRI, sedation and all that. And this patient was on oxcarbazepine and having multiple recurrence of seizures. So this patient was switched over to sodium valproate and completely became seizure free. So another case, 10-year-old boy with absent seizures who was on valproate, did not have a complete remission. So once you know this is childhood absence epilepsy, chosen the medication, first medication is appropriate, but he is not going into remission, so we need to add the second medication. So that is lamotrigine. The combination of valproate and lamotrigine is very good for absence epilepsy. So he became completely seizure free with addition of lamotrigine to the valproate. And this is very, very important single message that you can take away from this lecture. So whenever you start the medication, you don't look at the patient factors. You always look at the patient factors, disease factors, and the medication related factors. On the same time, you should have watch on the comorbidity also. This 3-year-old child was recently diagnosed with autism, and the child developed 3 seizures in two days, afebrile seizures. The child was started on levetiracetam, became completely non-manageable. So very violent, aggressive, shouting, crying, running amok, hitting self and all the family members, completely a different child. It was a disaster for the family. So this child with autism, we know levetiracetam is not the great medication because levetiracetam induces psychosis in these kind of patients. So better to avoid levetiracetam whenever a child has hyperactivity, bad behavior, or autism. So this is the single most important message that you all take away from this, because many a times often we come across patient with hyperactivity, attention deficit, and psychiatric disorder, depression, as well as autism, getting levetiracetam and ending up badly. So this is the last case scenario. 11-year-old child presented with multiple nocturnal episodes, brief, very bizarre behavior. Basically, these are frontal seizures. Never had GTCS, MRI normal, EEG showed right frontal spikes. So basically, this was a frontal focal epilepsy, multiple per night. So this is nocturnal frontal lobe epilepsy. So the child was treated for 2 months in another hospital. Child was on valproate. Child was on levetiracetam. These kind of patients with frontal focal epilepsy, they have executive dysfunction already, their bad behavior, but on top of that, levetiracetam was added, the behavior worsened further. So the importance of syndromic diagnosis, the moment you diagnose this patient as nocturnal frontal lobe epilepsy, you know which medication to choose. Oxcarbazepine was the drug of choice, carbamazepine or oxcarbazepine. So we started this patient on oxcarbazepine, went into partial remission. We added clobazam as a second add-on medication, completely seizure-free for 3 years now, and the executive functions improved, behavior improved, and we gradually reduced and stopped valproate and levetiracetam. So this is a classical example of focal epilepsy, which will not only respond to valproate, which will not only respond to levetiracetam when it is multiple daily seizures, but the side effects are much more. There is no response on one hand, multiple side effects on the other hand. So common scenario, you diagnose a patient with epilepsy and start the patient on medication, but the medication fails. What do you do? So single most important thing, you have to revise the diagnosis. Is it epilepsy that I'm treating? Or is it the appropriate AED chosen for the appropriate syndrome? Or the dose of the AED is adequate? These are the 3 common factors that we have to revise before we think about anything else. If the first AED fails, we can have alternative monotherapy, as I demonstrated in the previous cases. Instead of valproate and levetiracetam, we started the patient on oxcarbazepine, alternate monotherapy. Or if the medication is partially effective, as we had for the childhood absence epilepsy on valproate, partially effective, you can add on the second medication, that was lamotrigine. So common cause of AED failure, not to forget drug non-compliance, intercurrent illness, inappropriate AED, inadequate dose. And the single most important thing to remember here is therapeutic trial doesn't work in epilepsy. Say for example, there was a patient who had a repeated eye blinking episode. Basically, these were tics, non-epileptic behavior. Someone started this patient on carbamazepine and the episodes subsided. So that does not mean that this is a seizure. I had very much difficulty in convincing that patient that carbamazepine had a non-specific effect on these patients, and it is not proof that this is epilepsy. This is only tics that anyway would have subsided on its own. So just because some paroxysmal movement disappeared on anti-epileptic drug does not rule in the diagnosis of epilepsy. Most important. On the same note, Just because an AED is not effective, that does not rule out epilepsy. It may be a little bit paradoxical, a little bit confusing, but think about this in a deeper level, you will understand. Just because an AED worked does not mean it's epilepsy. Just because an AED does not work does not mean it is not epilepsy. So even after so many medications discovery, we still have patients, significant proportion that is drug resistant epilepsy. So we go through monotherapy trials, then we go through polytherapy, combination of 2 or 3 medications. And there are many synergistic AED combination. Valproate and lamotrigine is the most important combination for refractory absence epilepsy, IgE syndrome. Valproate, topiramate, and clobazam is very, very important combination for Dravet syndrome and generalized epilepsy with febrile seizure plus. So this is just to show you one case, 8-month-old infant. You can see continuous seizure activity going on. He used to have 100 seizure per day at 8 months. You can see there is a hypomelanosis of Ito on the left side. You can see on the left leg, foot, and the left loin, the hypomelanotic patch. So this child had hypomelanosis of Ito as well as large hemimegalencephaly on the right side. Hemimegalencephaly. So this patient was treated on all the antiepileptic medication that we can think of. Finally, we had to do surgery, disconnection of the right hemisphere to make him completely seizure free. So you can see how nicely that boy has grown up and he's walking with the left hemiparetic gait. So that anyway would have happened even without surgery because he had a right hemimegalencephaly. So that would have caused left hemiparesis anyway. So now he is completely seizure free for 4 years. He is attending LKG. He is cognitively nearly normal. So that's what epilepsy surgery can do. So in patients that can be cured with epilepsy surgery, like that baby, epilepsy surgery is the treatment of choice. Epilepsy surgery is not the last resort option. If that child had come to us at 3-month or 4-month old with multiple daily seizures with hemimegalencephaly, we would have done the surgery earlier than later. So neuroimaging is the key to suspect these cases that can be amenable for epilepsy surgery, a large gliosis, a small hemiatrophy, tubers, or Sturge-Weber syndrome, mesial temporal sclerosis, tumors, or cortical malformations, cortical dysplasias. All these are the candidates for epilepsy surgery. So when to refer a patient to higher center? Most of the times, the simple controlled epilepsies can be easily managed at pediatrician level, but the moment the child fails to have control with 1 or 2 anti-epileptic medication, that child needs to see a pediatric neurologist or neurologist depending on the availability. Obvious lesion on the neuroimaging, definitely you need to go through evaluation for epilepsy surgery. Infantile onset epilepsy is usually more difficult to control. They may be better off with neurologists. Known difficult to treat epilepsy like infantile spasm, Lennox-Gastaut syndrome, tuberous sclerosis with epilepsy, all these are difficult epilepsies even for neurologists to treat. So better they are cared for in a higher center than at pediatrician level. So to conclude, epilepsy treatment is tailor-made. Choosing the right anti-epileptic medication depends on the syndromic diagnosis, need electroclinical recognition and systematic approach for the precise diagnosis. Treat the patient and not the EEG report. Epilepsy surgery can be a curative option. Refer the patient to higher center whenever child is not responding to the first anti-epileptic medication. With that, I conclude and thank you all for patient listening.
Thanks, Dr. Lakshmi Narayan, for such a simple approach to stepwise approach to epilepsy syndromes and epilepsy condition in children. To summarize, history is very important, as he told. And one important thing I wanted to mention is when they are showing home videos, you should always take history also into consideration. Most of the time, they will not give history; they will show only videos without giving any history. What happens before the onset of episode and after the episode, also very important. So, and the important thing is you should do examination. Examination also sometimes gives important clue for the diagnosis and type of seizures also. And as he told, that EEGs should be taken into consideration along with the clinical diagnosis. You should not treat EEG alone. And MRI and other imaging are very important for etiological association. And before going for extensive metabolic test, there should be some clue should be there in the examination or imaging finding. Then only should consider for extensive investigation of metabolic workup. So instead of that, we can consider genetic test. So, and regarding treatment, he is already advised how to select the drugs. Not only the type of epilepsy is important, there are many factors you should consider before selecting the drug of choice in treating these children. And he explained in detail how to select the children for epilepsy surgery early, so that it gives better outcome rather than going for very late in the treatment. So, if any questions are there, it will be discussed.
Yeah, thank you, Lakshmi, for excellent talk. There are few questions. I think we have time to take them up. So first is, how important is it to do EEG and MRI or other investigations in a child with typical absence seizures?
So EEG is of course very important. So EEG will um, give the supportive diagnosis for to say that this is a childhood absence epilepsy. Definitely, we wouldn't do MRI for children with childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy. I tend not to do MRI for benign Rolandic epilepsy because the yield for MRI for these patients are very, very, very low, if at all. And most of the time, even if you find something, those are unrelated, non-specific finding. So better not to waste your time and energy and efforts there. So we wouldn't do MRI for a patient with childhood absence epilepsy. There are rare case reports with focal lesion causing childhood absence epilepsy also, but these are albeit very, very rare.
Yeah. There are a few questions about West syndrome. So one is, can hypsarrhythmia present without epileptic spasms? And also, if there are spasm but EEG not showing hypsarrhythmia, in both scenarios, how to approach? Should they be treated or not?
Yeah. So the first point, EEG showing hypsarrhythmia. As I told, EEG is a very subjective interpretation. So the same EEG, one person can call it hypsarrhythmia, the other person can call it it's epileptic encephalopathy, but it's not hypsarrhythmia. Other person can call it it's just generalized epilepsy. So it depends on who you talk to, right? So there are patients with epileptic encephalopathy without epileptic spasms. Not all the patients with epileptic encephalopathy will have infantile spasms. So there are EEG abnormalities that amounts to hypsarrhythmia, but the patient may not have had epileptic spasm. Patient might have had subtle other seizures, subtle focal seizures, or other atypical absent and other seizure types. So that is still epileptic encephalopathy. We should still treat those patients with almost similarly as how we would treat West syndrome. Having said that, you need a very long. Um, Recently, I had a patient who had a bilateral perioccipital gliosis, and this patient was lost to follow up from another neurologist, and these patients were already on Ayurveda, everything. But this time they came back because of the prolonged status epilepticus. So we recorded EEG overnight. To our surprise, parents did not recognize subtle infantile spasms that was going on all the time. So the spasms can be very subtle. The parents may not recognize. And if you record just half an hour EEG, you will miss that. You have to record longer EEG so that you will be able to record the epileptic spasms.
Okay. And spasm but with no hypsarrhythmia, would you treat with steroids?
Yeah, so hypsarrhythmia is one part of the evolution of the whole prolonged longitudinal clinical course of the West syndrome. So at some point, the patient might have had hypsarrhythmia, later it resolved. Still, they would have some background abnormality, some multifocal epileptiform abnormality. That's the most common second type of EEG that you get with the infantile spasm, multifocal epileptiform abnormality. We still treat them same way as we would treat them for hypsarrhythmia.
Okay. Another question is, if the spasm have recurred after treatment with oral steroids, ACTH and vigabatrin. So, what would you?
Yeah, that is all the time that happens, especially in symptomatic cases. Especially the in our scenario, most of them are post perinatal ischemic insult or neonatal hypoglycemic brain insult or post meningitis sequelae. So in this scenario with gliosis, many a time there will be initial remission with steroid or vigabatrin. Following that, the moment you taper and stop the steroid, almost 1/3 of them they recur. So those kind of patients we treat with different combinations of anti-epileptic medication. Some of the anti-epileptic medications are found to be very effective in refractory infantile spasms. The examples are zonisamide, topiramate, lamotrigine in a combination of valproate and clobazam. Nitrosapam is another important effective medication. Clobazam works same way. So a combination of valproate, clobazam with one of these zonisamide, topiramate or lamotrigine, that combination tend to work for at least some of the patient, at least partially. It can be very frustrating situation to treat these patients because it's not all the time long-term remission. Dr. Raju, would you like to add something to this?
If a child
Yeah,
has
their
if a
question
child has
is
good,
whether,
yeah,
good
please.
response, whether you can repeat the course of steroids.
Yeah, that's what I wanted to say.
So if there is a good response and it has no much side effects, if there is a good response, you can repeat course also.
How long after the first course would you repeat the course of steroids?
Maybe if there are not much side effect, if the child relapse was there after maybe 3 months, you can consider.
Yeah, but the practical scenario is the moment you give the second course for few 1 or 2 3 months, they'll be in remission. Again, they'll go back to the recurrence. We have had patients third course, fourth course. Even after that, there'll be temporary remission. Then they go into relapse. So it's almost like a steroid dependent state. How long to give that will be a problem.
Okay. So just briefly, can you tell what is the treatment and prognosis of DOOL syndrome?
DOO syndrome is excellent prognosis. Many a times, initially the seizure can be frustrating to control, but over time, with a combination of medication, again topiramate, sodium valproate, and clobazam, these are some of the very good medications. And especially if they are not responding to medication, they are some of the syndromes that give excellent treatment response to ketogenic diet. So DOO syndrome, if they are not getting controlled with medication early on, this is one of the syndrome that you should think about, start them on ketogenic diet or variants of any dietary therapy early on. So they have excellent prognosis long term.
Okay. Is there any difference between Beck's and benign Rolandic epilepsy? PCTS and benign Rolandic epilepsy?
They're the same. They're the same. Oftentimes, multiple different terminologies have been used. The most recent 2017 ALE classification, these are called now self-limited pharmacoresponsive Rolandic epilepsy, just to avoid the term benign. So they are all the same thing.
So Kaushik has asked, what's your take on pyridoxine among those with levetiracetam-induced behavioral side effects instead of withdrawing them immediately?
Yeah, that's a very interesting question. There is no solid evidence, but practically we have used for many patients. Some patient it really helps. Say for example, levetiracetam induced anger outburst, hyperactive behavior. If you give pyridoxine along with levetiracetam, uh, that the behavior improves. But again, it's not in all the patients. Some patients show good improvement. The evidence is not there. It's all anecdotal.
Okay. Another question is, if a child comes with status epilepticus and you have loaded with phenytoin or fosphenytoin, can you discharge that child on oral valproate instead of phenytoin because the child is still under the evaluation of epilepsy? So what do you do to discharge on
That
phenytoin or valproate?
Yeah, that's a very good question. That depends on the scenario. So, for example, the moment you have given a loading dose, and basically the loading dose take care of 4 or 5 half lives, right? So if there is no ongoing insult, if there is no ongoing seizure, then definitely that will take care of in the initial 1 or 2 days. And by the time if you have started good dose of valproate, then that can take over. Some patients can go without any problem. But on the other hand, there is an ongoing insult, there's an ongoing seizure tendency. Say, for example, there is a tuberculoma or neurocystic sarcosis sitting there that is very active, that is throwing seizures more frequently. So this will fail because you already given a loading dose of phenytoin. Better to maintain that patient with phenytoin itself for that patient that has an active tendency to seize. Practically, clinical sense, how do you differentiate between a patient that will settle down, patient that will continue to have seizure? that cannot be determined clinically.
Okay. Yeah. So, what is the role of continuous prophylaxis in a case of recurrent febrile seizure with very apprehensive parents, even after an extensive counseling?
Yeah, this question is not surprising. Always this comes up. Uh, See, the literature wise, it is very evident that there is no role for daily anti-epileptic prophylaxis for how much ever recurrent febrile seizure. And in Western countries, they don't treat. Even after 4 or 5, 6, 7 episodes, also they don't treat. I've come across patients with febrile status epilepticus. Every time they come with febrile status epilepticus in the Western situation, they are not put on any anti-epileptic medication long term daily. That is there. Having said that, many a times febrile seizure is a mixed bag. It's not a simple homogeneous condition. When the concept of febrile seizures discussed in the original period, it was basically the immature brain having tendency to have seizure. In that concept, usually the patient have 3 or 4 seizures in their up to 5 years, 3 or 4 seizures, not more than that. But nowadays, with the genetic and all that thrown up, with the SCN1A and other genetic factors, if you take into account, many of those kind of patients will have a multiple recurrent febrile seizure, 10 episodes, 15 episodes. Those kind of patients definitely are not just a simple febrile seizures. They are genetically predisposed patients with epilepsy with fever triggered seizures, what we differentiate as. So they benefit by treating. So it depends on what is the label you give, it depends on what we are dealing with. If it is only simple febrile seizure, definitely no. But on the other hand, there is a generalized epilepsy with a febrile seizure plus that kind of phenotype that is usually diagnosed by 5, 6 years. By 1 or 2 years, you can't diagnose that without the genetic testing. So we have come across patients with multiple hemiclonic status epilepticus in the scenario of SCN1A. They will definitely benefit by long-term daily anti-epileptic medication. So we need to be careful what we are talking about when we talk about febrile seizure.
So, another question is, what's your experience with brivaracetam when there are behavioral issues with levetiracetam?
Yeah, like we don't have like huge experience, but a little bit of experience what we have. Brivaracetam is definitely much better in terms of behavioral side effects compared to levetiracetam. Previously, those patients, I've had adolescent patients who had suicidal tendency and very bad behavior, aggression, all that. While on levetiracetam, they were switched over to brivaracetam. They are doing much better. They are doing well. So definitely there is a benefit in terms of behavior side effects.
Okay. Dr. Raju, you have experience with brivaracetam?
You have to
You're
unmute,
muted.
sir.
Brivaracetam you're using, but you are commonly seeing side effects. The behavioral side effects is quite common in that also. So it is not so less compared to levetiracetam. Maybe a little less, but it is commonly seen behavioral side effect commonly in brivaracetam also.
Okay. Okay. When should we consider checking drug levels, serum drug levels?
So therapeutic drug level monitoring. So there are different scenarios. Say, for example, if the patient is in the ICU with refractory status epilepticus or super refractory status epilepticus, you have already given multiple loading doses of phenytoin, phenobarbital. Definitely, you will check. You will check. But on the other hand, it's a chronic epilepsy, outpatient management. We tend to not do therapeutic drug level monitoring to the extent in the last 6, 7, 8 years of chronic epilepsy patient management. So many patients in the outpatient scenario, we don't do routine drug level monitoring for valproate or phenytoin or carbamazepine or any other medication for that matter because they are not cost effective. Second, even the patient is clinically seizure free, you do a drug level, it comes as subtherapeutic, you're not going to put up the medication dose. So that is a very important factor for us to understand. If the patient is clinically seizure free, just because the many time that is done by pediatricians and other doctors, like valproate level is taken, child is completely seizure free for last 1 year, 1.5 year. Valproate level is 20, 30. Then they increase the dose, they increase the dose, they again do another level 2 months later, they increase the dose. That is not needed. So still the titration is clinical. You are not going to titrate based on just drug level monitoring. So for OPD patient, we don't do. For inpatient ICU management, definitely there is a role.
Okay. So how do you manage excessive weight gain with sodium valproate?
It's a very good question, especially post-pandemic lockdown scenario. There is a lot of weight gain going on. The obesity epidemic has multiple times exponentially grown. So it's definitely difficult, and the people attitudes also have changed a lot in the last couple of years. What you see previously, if you point out the child is bit overweight and you need to take measures, they take it bit more receptively. Nowadays the receptiveness is not there, both from the children and the parents point of view. They many times get offended because so much going on in the social media space regarding body shaming or whatever. So it becomes a not a medical issue, it becomes unnecessary a social issue. So purely medical issue that can be treated medically becomes a lot of social connotation. So it's a bit difficult, and adolescent age group very difficult nowadays with weight reduction measures and other things. Yes, like for some epilepsy syndromes like juvenile myoclonic epilepsy or idiopathic generalized epilepsy, um, the sodium valproate is the drug of choice. So many a times the moment you try to take off the sodium valproate for weight gain or for other reasons, how much ever other medication you give, they don't get controlled. So seizure control is one of the most important aspect of the epilepsy management. Even though all other holistic things also have to be taken care of, especially juvenile myoclonic epilepsy, adolescent, young adult age group, college going, they don't sleep properly. Juvenile myoclonic epilepsy, first treatment is sleep, so they don't sleep on time, and you are taking off valproate and they are already obese, any number of other medication won't work. So we have to be a little bit more balanced on what we are trying to do. Many a times I've counseled patients not to come off sodium valproate for hair loss. Hair loss is another most common reason now people want to come off sodium valproate, like patient choice. So I have counseled many patients not to do that because seizure control will get hampered. Practically that happens, and 6 months down the line we end up restarting the patient on sodium valproate. So smaller dose sodium valproate, that is uh, unfairly blamed for many of these side effects.
Okay, last question is where do you put brivactam and perampanel as first add-on or in refractory epilepsy?
As of now, at least in pediatric age group, we are not talking about first add-on for these medication, brivactam and perampanel, still or second, third, fourth add-on as of now, evidence-wise as well as practical use-wise. But if you are asking about certain scenarios where you can use them as a first add-on or yearly add-on, definitely some of the epilepsies like perampanel efficacy for juvenile myoclonic epilepsy, the refractory IgE, the thing that we just spoke about, like you are trying to take off valproate and the patient becomes refractory IgE, that is the situation. Perampanel works wonders because up to 80% seizure freedom rate have been reported in juvenile myoclonic epilepsy, juvenile absence epilepsy, even childhood absence epilepsy that are refractory to other medication. So in them, after valproate, after levetiracetam, you can try perampanel. That is one situation. Second, if you have already tried the patient on levetiracetam, so you want to switch over from levetiracetam to um, brivaracetam, that is one of the early indication that you can go for. Despite there are other medication that are there, so with the view, most likely you can come off other medication that are there. Only you can keep the patient on brivaracetam monotherapy also.
Okay. So thank you. It was exhaustive question answers, and thank you for answering them all. I think it was a very good session, and there are so many messages for it being an excellent talk. So thank you, Dr. Lakshmi. So Dr. Naveen, any last words from your side? You just came on the camera, so I just.
No, thank you. Please continue.
Okay, I think we should call it a day then, and next week's Sneha, are you there? Yeah, just to tell you about next week, it's a very interesting topic as we are celebrating this as a Epilepsy Awareness Month. Next topic will be on neuromodulation for epilepsy. It will be by Dr. Robert Fisher from California, and moderator will be Dr. Sanjeev Thomas, who is the director of ICCONS Trivandrum. So it will be coordinated by Dr. Vishal. So please, all those who are interested, attend this session. It will be a very good session on VNS and other neuromodulations. Thank you all. Thank you once again.
Thank you, sir. Thank you. See you.